All right, welcome everyone. So the topic we will discuss today is high yield X-ray series, shoulder, clavicle, and elbow. My name is Dana Sheng. I'm a sports medicine physician at Dignity Health, and I'll be your moderator for today. Next slide. So this lecture series is sponsored by the AMSSM Online Fellows Education Subcommittee, co-sponsored by the Education Committee and the Fellowship Committee. Before we get into our topic for tonight, I want to remind everyone, next slide, of next week's lecture on high-yield medical topics for the training room, which will be given by Dr. Jim Mulder. And then next slide. The goal of this lecture series is to serve as an adjunct to your individual fellowship program education and to provide sports medicine fellows with direct access to learning from experienced AMSSM members and guest speakers in a variety of formats. Finally, this is also meant to assist in CAQ exam preparation. Next slide. Some reminders, make sure to mute your microphone and turn off your video. You can submit questions at any time through the chat function, and feel free to include your name and program if you wish. At the end of the talk, I, as the moderator, will ask the questions during the Q&A based on the questions you submit. After the program, we would love your feedback. One of our new efforts, new slide, is to facilitate more input from our audience. There are a couple ways to do this. First is a web link can be found by going to amsssm.org, click on the Education tab, and then select the Fellow Online Lecture Series. The link is located near the top of the page as seen in the screenshot. Second way is by scanning the QR code, and it should take you directly to the form to fill out. When filling out the form, we ask that you please keep in mind that the primary goal of the series is to assist in CAQ preparation for fellows. And now I'd like to introduce you to our expert speaker today, Dr. Robert Boutin. Dr. Robert Boutin is a clinical professor of radiology at Stanford and is the director of their Musculoskeletal Imaging Fellowship. He has served as chair of the Musculoskeletal Imaging Program Committee for the Radiological Society of North America and is president of the Society of Academic Bone Radiologists. He has served as guest editor for Orthopedic Clinics of North America and for seminars in musculoskeletal radiology. Dr. Boutin has also served as editor-in-chief of Current Radiology Reports. He has also been an invited lecturer for continuing medical education courses for RSNA, the International Skeletal Society, the Arthroscopy Association of North America, AAOS, and the International Society for Magnetic Resonance in Medicine. And with that, thank you, Dr. Boutin. Thank you so much for being here.
Dana, thank you so much for having me to this high-yield X-ray series. We'll be talking in particular about shoulder, clavicle, and elbow. Our objectives are to first just review a universal checklist that's good wherever you go in the world, wherever you go in the body, looking at X-rays, the so-called ABCDEs. And then we're going to just briefly review some common derangements that we see on radiographs, and then throw in some correlation with CT and MRI of those derangements. Let's start with the shoulder, recognizing, of course, that soft tissues are better evaluated on ultrasound and MRI than on radiography, and also that non-displaced fractures can be missed sometimes on radiographs. So advancing to some additional advanced imaging, such as CT MRI, is sometimes worth doing. So the routine series of X-rays for the shoulder varies depending on physician preference and the institution. A lot of times it's some sort of frontal or AP view, either of the shoulder or of the glenoid. When it's an AP of the glenoid, like we see here, that's called a Grashy view. And you can see the normal joint space and normal alignment of the glenohumeral joint. Then there's the outlet or transcapular Y view, the Y created by the scapula, and there are a lot of overlapping structures here, but the glenoid is in here, and the humeral head is also here overlying it. So it's normally aligned, and you can see a nice type 2 or curved undersurface of the acromion. And then after the frontal view and the outlet view, there's ideally some sort of axillary view or an angled axillary view like we see here. Also to confirm that the glenohumeral joint is normally aligned. So here the glenoid and the humeral head are congruent. This Velpu view, an angled axillary view, is favored increasingly by some orthopedists because it can show a Hill-Sachs lesion, and if it's present, a bony Bankart lesion at the anteroinferior margin of the glenoid. So just a brief overview of a systematic approach for approaching radiographs. Obviously, we want to make sure that the joints are normally aligned, looking both at the glenohumeral joint, this on an AP view of the shoulder rather than the glenoid. So you can see there's this normal overlap of the humeral head and the glenoid, normally aligned. And then sometimes it can be sort of tricky looking at the alignment of the AC joint, but I find it particularly helpful to follow the undersurface of the clavicle and make sure that it lines up with the undersurface of the adjacent acromion. Sometimes there are osteophytes or things can look sort of funny if you follow the superior surface, but I would encourage you to look along the undersurface for that normal alignment like we see here. And then there are a lot of other things that we include in our systematic approach. B for bone density, looks normal here. The cartilage or joint space gets narrowed with osteoarthritis, but here it's a nice normal AC joint space, for example. If we're looking at an arthritis, it's often helpful to look at the distribution of an abnormality. And then, of course, also with an arthritis in particular, it's helpful to look for erosions. Sometimes that's easy to remember by remembering the ABCDEs. The S actually can stand for the soft tissue. Don't forget to look in the soft tissues, even on radiographs, since it can sometimes be the important key to making the right diagnosis, as we'll see. Usually not, but sometimes it is. So here's an example of a normal AP view of the glenohumeral joint and AC joint. So normal shoulder. All right, well, what's wrong with this? Just a quick warm-up case. This first stop, of course, we look at alignment. And here, as we follow the undersurface of the distal clavicle, it, of course, does not line up with the undersurface of the acromion. And this is abnormal alignment, the so-called grade 3 or type 3 AC joint separation or dislocation. So that's pretty straightforward, but there are occasionally some curveballs. So here's a 28-year-old athlete. Is this just another one of these grade 3 AC joint separations or dislocations? So there's the undersurface of the clavicle. Here's the undersurface of the acromion. Clearly, it's dislocated superiorly, tending the skin. This is abnormal. But as we look at this, you can see that the distal clavicle is actually projecting posterior to the acromion. And this actually makes it a grade 4 dislocation. So here's another example of a case of a grade 4 AC joint injury. Here, actually, it looks like it's normal alignment on the AP view, but on the axillary view, here, just a straight axillary view, here is the distal clavicle, and here is the acromion, and you can see that they are not congruent. The distal clavicle is dislocated posteriorly relative to the acromion. So sometimes it's a pretty hard diagnosis to make that grade 3 to 4 differentiation. And so this was a case where the radiologist read it, a very good radiologist, fortunately it wasn't me, read this as a grade 3 dislocation. Well, it looks like it there, but the orthopedist, who was a subspecialty shoulder guy, was concerned that it was a grade 4 dislocation and ordered a CT. This is a 3D reformation showing the distal clavicle back here. Here's the acromion. And because it's a 3D reformation, here's the humeral head. We're looking down on top of the shoulder, and this might possibly orient you. It's like we're looking down on the shoulder from above. So just be aware that if the distal clavicle is displaced posteriorly, the surgeons do care about that, and it tends to make it an operative case. Okay, next case, a 48-year-old gentleman. You can see the metallic button or endo button from a biceps tenodesis. It seems like often orthopedic surgeons, when they are working on the shoulder, have a hard time leaving the AC joint alone, and not infrequently will do a subacromial decompression or acromioplasty. The acromion will look a little thinner. So here you can see, even though they're 48, this looks a little too good. They've had a subacromial decompression. And the reason I bring this case up is that so often for radiologists who are in training, they will see a wide AC joint, sort of hard to see where the distal clavicle is here, but often there will be a wide AC joint, and the neophyte radiologist may call widening of the AC joint when in fact they've had a subacromial decompression and a distal clavicular excision, a so-called Mumford procedure. So we sometimes joke that we learn a lot about differential diagnosis of imaging findings, but if it's something that looks confusing, the differential diagnosis includes that a surgeon has been there. So wide AC joint, there's a differential for that, but most commonly in clinical practice, it's because a surgeon has been there and it's a post-op finding after a Mumford procedure. Okay, next, a 21-year-old with a skiing injury. Clearly, this shows an dislocation, an anterior dislocation of the glenohumeral joint with the humeral head dislocated antero-inferior to the glenoid. And this is redemonstrated on the axillary view glenoid and subcoracoid positioning of the humeral head antero-inferiorly. Post-reduction, we have these radiographs, and the question for you is, so what findings might you be looking for? Well, of course, one set of findings that you might be looking for on an internal rotation view is a impaction deformity at the posterior-superior lateral aspect of the humeral head. It's a little bit easier to see sometimes on cross-sectional imaging. Here on the corresponding MRI, you can see the bone edema because it's a recent Hill-Sachs impaction deformity. The more medial the defect extends, the more likely it is to be an engaging Hill-Sachs lesion, and the patient will need to undergo surgery to prevent recurrent dislocations. And then the companion finding shown here, if we had a multiple choice, it would be that this patient has a bony Bankart lesion at the antero-inferior glenoid. So just driving that point home, what two things would we be looking for after an anterior glenohumeral joint dislocation event, which is at least 95% of all glenohumeral joint dislocations, in addition to that Hill-Sachs lesion defined as a posterolateral humeral head compression or impaction fracture. As in this case, we look for a Bankart lesion. They're easiest to see when they're bigger and bony, like in this case. And let me just see if I can move that. Here you can see there's also this blunting deformity at the antero-inferior margin of the glenoid on an MRI, indicative of an injury, a so-called Bankart injury, involving both the glenoid rim and the labrum as well. So we've talked about alignment, and we've talked about the injuries that can occur. Typically, it's an antero-inferior dislocation at least 95% of the time. Sometimes the fractures are small and relatively difficult to see, but you sort of try and look through the bones and see them as best you can. And then, of course, looking at your usual checklist of things, the so-called ABCDEs. Okay, so let's take a look at some more cases here beyond just this sort of simple anterior dislocation. Here is a patient presenting with pain after an injury, and we're given two frontal views. The patient had difficulty getting an axillary view. The technologist wrote a note that they couldn't do it, and so, what are you going to do? How are you going to interpret this case? Well, they did, because they couldn't do a regular axillary view, they tried doing the Y view, transcapular Y view, or outlet view. And these are always a little bit challenging because of all the things that are overlapping, but we can see that here is the scapula, the so-called Y is something like this. So the glenoid should be here. You always know that the coracoid process is projecting anteriorly. And so here we have the humeral head projecting a little more posteriorly than we would like. It turns out that these features are characteristic of a posterior dislocation. The radiographs that we were looking at shows what looks like an impaction deformity, but this time, rather than being at the posterior-superior lateral aspect of the humeral head on an internal rotation view, it's in a less conspicuous location, a less common location, and it turns out that this impaction deformity in the humeral head anteromedially is because the humeral head is dislocated posterior to the glenoid. So I've shown the glenoid and the humeral head posterior to it. This is a posterior dislocation. And these can be challenging. Cross-sectional imaging with CT or MRI can prove the case because they're often missed initially. Here you can see that impaction fracture at the anteromedial humeral head. And the humeral head is actually perched at the posterior rim of the glenoid. And so the patient cannot freely internally and externally rotate. So the sequelae of a posterior glenohumeral joint dislocation include a reverse Hill-Sachs impaction deformity at the anteromedial aspect of the humeral head and a corresponding injury at the posterior glenoid. So either a posterior labral tear or a posterior labral tear accompanying a posterior glenoid fracture, the so-called reverse Bankart injury. So the humeral head is a little bit posteriorly translated relative to the midpoint of the glenoid. You can see some edema signal along the subscapularis anteriorly as well. Here's another case, a companion case, but a different case showing similar findings. Let's run through this. Here's the AP view. This is supposed to be the AP view of the shoulder, here the AP view of the glenoid, and they look pretty similar. So if we were given a multiple choice of which of a number of things occurring in the shoulder we're dealing with, we would want to choose that this is a posterior dislocation. Why would we choose posterior dislocation? Well, first of all, I'll mention that we know, although these injuries are uncommon, about 3% of glenohumeral joint dislocations, they're missed initially a whopping, some literature would say, 50% of the time. So here in the sagittal plane on a CT, the corresponding images for that patient show the glenoid, this flattening deformity posteriorly, and then the humeral head is dislocated posteriorly. Again, for orientation, we always know that the coracoid process is projecting anteriorly. So this is characteristic of a posterior glenohumeral joint dislocation, characteristically seen with a posterior vector force with trauma when the humeral head is driven posteriorly, as well as when a patient has had a seizure, which can be due to an electric shock, forceful internal rotation, and the humeral head is driven posteriorly, resulting in the deformities that we see here in the humeral head and posterior glenoid. Clearly, a lot more difficult to see what's going on the axillary view on the radiograph, but you can, with the help of the CT, hopefully make out the impaction deformity at the anteromedial humeral head and this remodeling deformity that has occurred in the non-acute setting at the posterior glenoid rim. It's common in these patients to have loose bodies or joint bodies, and often advanced imaging like an MRI might be done before any definitive therapy because that affects the treatment and prognosis for the patient. Also, cross-sectional imaging might end up being ordered after the radiographs, not only because these cases can be challenging, but also because the size of these impaction fractures and joint bodies may affect the surgical treatment. So when you see a glenohumeral joint that looks like it's in internal rotation, and you've asked for internal and external rotation views, and all you're getting are internal rotation views, that's going to be something that should raise your suspicion. We know it's an internal rotation view when the humeral head looks sort of like a light bulb, whereas if it's an external rotation view, you'll see the greater tuberosity in profile. So the person, the shoulder is perched, the humeral head is perched in internal rotation. You have this compression fracture deformity at the anteromedial humeral head, the so-called trough sign, and then a joint body in the axillary recess. This diagnosis was missed for 3 years, and so it's worthwhile, even though they're uncommon, to have some index of suspicion when you see something that's funny and unexplained in a glenohumeral joint. Of course, there are other areas of malalignment that other patterns that can occur. One uncommon one, less than 1% of dislocation, so-called luxatio erecta, like somebody raising their hand in class. You can see that the humeral head is caught inferior to the glenoid, and they're caught in abduction. When they do finally get reduced, it's easier to see that they've got fracture fragments. Here, a comminuted fracture involving the greater tuberosity that you can more easily see on CT and its positioning after reduction. Okay, here's a hockey player with anterior pain. Didn't really have any trauma, but he was a hockey player. What's going on? Well, as we look at the findings, we've talked about looking for radiodensities, but just because you see a radiodensity in the soft tissue, of course, that doesn't necessarily mean that you have a fracture, particularly if there's no trauma. And commonly in the shoulder, of course, when you see this amorphous calcific density in the distribution of the rotator cuff here, the subscapularis tendon immediately superficial to the lesser tuberosity, we know that that represents calcific tendonitis, calcium hydroxyapatite crystal deposition. Okay, what about this case? Pain after a fall. This, when we do our M&M conferences in radiology and review our misses, this one is a perennial favorite for misses. You can take a look and see if you see the abnormality. There it is. You can see this subtle cortical irregularity, subtle linear lucency right here. And that represents a greater tuberosity fracture that's essentially non-displaced. Sometimes when they're non-displaced and subtle, it takes an MRI or a follow-up exam where they start getting some sclerosis along the fracture line. But here you can see the cortical step-off here and here, as well as all this bone edema in the acute setting with an essentially non-displaced greater tuberosity fracture. Of course, we look for this fracture fragment sometimes to get displaced superiorly, in which case it may become an operative case because that if it heals with superior displacement, then there can be narrowing of this subacromial space, and that can be problematic. All right, well, what about this case? A 38-year-old gentleman fell off a bike. He was diagnosed with AC osteoarthritis and a congruent glenohumeral joint. We look and we see this is an AP view of the glenohumeral joint, not the glenoid. So AP shoulder, not a Grashy view. You can see this normal overlap of the glenoid and humeral head. You can see there's also this normal alignment at the undersurface of the clavicle and the acromion. And I will tell you that the clavicle is sort of a funny bone. It has sort of a little bit of an S shape. And so depending on the projection, it can look quite different. But here, clearly, there is this articular surface step-off and arguably some fracture fragments here. So when one performs an AP view with increasing angulation, like cephalad angulation of the X-ray beam, you can see more easily that indeed there is this inferior displacement of the distal fracture fragment by more than half a shaft width at the midshaft of the clavicle. On follow-up, they tried treating him non-operatively. On follow-up, there was increasing displacement, and then you can see non-operative treatment continued to fail here on a 30-degree cephalad angulation view. You can see the comminuted fracture. This is not going to heal. It's tenting the skin. And so, not surprisingly, this person went on to have an ORIF, open reduction internal fixation, often performed with reconstruction plates and screws. They tried to get the major fragments, and so this patient had a good result. And sometimes the radiographs will be performed so that you can see both clavicles at the same time. And then, for example, if you're worried about an AC joint injury that isn't manifested on regular static views, you can have them hold weights and you can see if there's any subluxation here. So this is, again, normal alignment on the contralateral side. Here is a 61-year-old who fell off his bike. And here, of course, when we look at the alignment, the glenohumeral joint's looking good. The AC joint alignment is good, but there is this fracture. One of the other pitfalls that we are very aware of in radiology is called satisfaction of search. So we know that Homo sapiens, when we see one thing that we're looking for, we relax and stop looking quite so hard. So, you know, people give their high fives. Oh, he's got a distal clavicle fracture. And here I'm just giving a cone down view from his chest CT, also showing that that fracture in the distal clavicle. What else could possibly be wrong? What possible blind spots or pitfalls are there in evaluating the 61-year-old with a fall off of his bike? Well, here's one of those views where you can see both clavicles and AC joints to look for alignment. So here again, they're following him up, and you can see the fracture. There's some callus coming across it, but the patient was symptomatic. And as we look a little more closely, we can see the normal side. Here is the medial clavicle head. It's really hard to see the SC joint. So if people are worried about the SC joint, they are encouraged to get cross-sectional imaging. It can be ultrasound. You can actually see malalignment of the SC joint on ultrasound sometimes, but CT is sort of the go-to definitive favorite among most radiologists. And you can see, whereas this normal side has a smooth contour, here it looks like it does not have a smooth contour. It looks like the medial aspect of the clavicle that had this fracture also has another deformity more medially. They didn't know what was going on. They ordered a CT arteriogram to look at his carotids, but you can see on successive images, there's this intra-articular fracture involving the medial aspect of the clavicle that was present. There's a little bit of widening of the sternoclavicular joint, but no anterior posterior dislocation or subluxation was present. Of course, we worry in particular about posterior translation of the clavicular head, because that can embarrass the adjacent great vessels posteriorly. So be aware that it's a real blind spot, the SC joint and the medial clavicle. And just in general, when you see one thing, don't forget to keep on looking, even though it might be sort of an inconvenient truth. Okay, let's move on to the elbow. The elbow, we know most commonly for a routine series, it's 3 views most commonly. Here, the AP view, here an oblique view, so that the radial head is projecting off of the adjacent ulna, and then the lateral view. Obviously, we want to make sure that the anterior aspect of the humerus goes through the capitellum, and that the radius also goes through the capitellum. And then when you see a linear lucency, be aware that there are these vascular channels that occur. So you can see this linear lucency parallel to my red line. This linear lucency is a vascular channel going through the anterior cortex, not to be confused with a fracture. So there are many of us reading out cases on radiography will have a normal variance book, and will, if we forget, people can look up easily where these vascular channels are. So what about this case? Pain after a fall. We have the AP view. We can see that it looks pretty good on the AP view, but on the lateral view, we can see, even though the alignment is pretty good, we don't see any subluxation or dislocation. We've got to see this big displaced anterior fat pad. This fat pad should be closely opposed to the humerus, but this thing is really displaced anteriorly like a sail. And we shouldn't see the posterior fat pad, but you can see it here. And if we look closely, as we do here, we can see this fracture, this linear lucency in the radial head. We see those all the time, of course. Sometimes it's hard to see on the lateral view. It's probably right here, going like this. But just be, as you know, these can be subtle and essentially non-displaced, but in the setting of trauma, when you see a fat pad consistent with a joint effusion, it's a fracture until proven otherwise. So here, just blowing it up a little bit, here the intra-articular fracture of the radial head, and here these displaced fat pads, indicative of a joint effusion in the setting of trauma. I will say that we sometimes see displaced fat pads without trauma. What could cause that? We see it when there's synovitis, when there's something in the joint. So say somebody who has an inflammatory arthritis like rheumatoid arthritis might have a bunch of synovitis in the joint, even without trauma, that causes fat pad displacement. And occasionally there will be an intra-articular tumor like tenosynovial giant cell tumor, formerly referred to as pigmented villonodular synovitis, PVNS, that can be an intra-articular space-occupying lesion that causes these fat pads to get displaced. All right, here a 19-year-old male elite athlete, just running you through some variations of injuries that can occur, often with a fall on outstretched hand. The AP radiograph shows this linear lucency extending across the base of the lateral humeral epicondyle and to the what looks like the margin of the humeral condyle. Here again, just getting more practice looking at these displaced fat pads. They're often faint, but this one is, again, displaced like a sail, and we should not see this posterior one, but we do an effusion in the setting of trauma, fracture until proven otherwise. So this is a lateral condyle fracture, also involving the epicondyle. And just to prove it to you, so here are these fat pads that are displaced. It's just their fat pads. Here is the big hemarthrosis in the joint. Here's the big hemarthrosis in the joint and the displaced fat pad posteriorly. And you can see on the CT just how extensive and comminuted this was, extending to the articular surface with small adjacent fragments that are helpful in further characterizing the injury. Next, pain after a fall, another set of elbow radiographs. The AP view doesn't look half bad. Looks like things are aligned okay, but on the lateral view, we see a posterior fat pad after a fall. Well, we better find the fracture and this displaced anterior fat pad. What are the findings? Well, this is a humeral capitellum fracture. Usually you would see the humeral capitellum in better here, but because it is fractured and rotated, as you can see here, this is not well seen on the AP view and could be easily missed if you only had the AP view. But this fracture fragment here, the humeral capitellum, is displaced anteriorly and rotated about 90 degrees. So here, just showing it in a little more detail, this humeral capitellum fracture. So small fractures can be challenged to see not only on radiographs, but particularly on MRI. And so if we are looking on MRI only without radiographs, we can miss little fracture fragments. Here's a 42-year-old guy who fell playing football. The radiology resident looked at this and said, okay, I can see some stranding in the posterior soft tissues. They've got soft tissue swelling, but they looked and they didn't see any displaced anterior fat pad, so no effusion in the joint. And they were very happy to see that then they could relax. They didn't have to worry about one of those subtle radial head fractures. But we know that a common pattern of injury is for people who have an enthesophyte being defined as an area of ossification or mineralization at a ligament or tendon attachment to bone, that these enthesophytes are a weak link in the biomechanical chain. And when a strain is placed on the system, you can get a fracture through the enthesophyte. Here, of course, the insertion site for the triceps tendon, and that enthesophyte can then get displaced proximally. The triceps contracts, pulls this enthesophyte more proximally, and you can see just sort of how subtle this little ossific fragment is on MRI, but here is the triceps muscle. Here's it coming down into the triceps tendon, and then there's that soft tissue edema that we saw. I will tell you the entire secret of interpreting MRIs of joints is to know your tendon, know your attachment sites, know your anatomy. So in this particular case, if we see fluid where there should be tendon, we know that tendon should be attaching to the olecranon. This is the footprint for the triceps tendon. And because we see bright fluid signal abutting the olecranon, we know that the triceps is torn or there's an avulsion. So with flexion of the elbow, this fragment translates a little more proximally than with the elbow and near extension on the MRI. So long way of saying this is a distal triceps tear. Often surgeons will want to debride these little avulsion fragments when they go in and do the repair. In at least a third of the cases, you'll be able to see this avulsion fragment when there's a distal triceps tear. So be aware of these little fragments, avulsion fragments. Now, I will tell you that not all foci of mineralization or ossification posterior to the elbow represent avulsion fractures. Here, you can actually see that there are multiple foci of radiodensity, multiple foci of ossification. They're outside the joint, so they're not joint bodies. And the patient, a 46-year-old guy, had a workers' comp injury. So they got an MRI, and on the MRI, we know that areas of dense mineralization will look like they're low signal intensity on all pulse sequences. We know that on a T1 weighted image, if we see high signal intensity in a lesion, just like when we see it out here in the subcutaneous soft tissues, that's fat. And then when we see serpentine tubular channels, we know that that's something we can see with vessels, right? So putting it all together, the diagnosis here is a venous malformation, a slow flow vascular malformation, what we commonly refer to in general practice as a hemangioma. So here post-GAD, you can see it's actually enhancing. So there is potentially a differential diagnosis from an imaging standpoint, and it's very helpful to know that when you see these sorts of areas of mineralization and the distribution of the distal triceps, that the patient hasn't had any trauma. And in fact, it turns out that this is a patient with one of these low flow venous malformations or hemangioma. And they can be difficult to diagnose when they're low flow, that is non-pulsatile. They can be more confusing on clinical presentation. They can enlarge somewhat quickly clinically if they have a thrombosis and get swelling, or if they have trauma and there's bleeding in the area. So just finishing up in the last couple of minutes, a couple final cases not to miss. 12-year-old girl, pain after an injury, AP and lateral views. Arguably, there is a sale sign here. PEDS cases can be tough. It's helpful to know your apophyses. If in doubt, you can always call upon some cross-sectional imaging exam. Here in the sagittal plane, there's something in the joint causing this widening of the joint space. And as you look here, you can see that fragment and this widening of the joint space. You can also see it here with widening of the medial joint space compared to the normal lateral joint space. This is a medial epicondyle fracture that is displaced into the joint, and you do not want to miss these. But this is a classic injury. It's classically missed, and it's classically something that goes to court when it gets missed. So just have a high index of suspicion for consulting your friends and neighbors who are experienced in these injuries if you're in doubt. One more sort of companion case. These young kids don't all get medial epicondyle fractures, but I will tell you that in both kids and adults, fractures at the coronoid can be easily missed. On lateral radiographs, that this area often is overlapped by adjacent bones and can be hard to see. On cross-sectional imaging, you can see that there's blunting of where the coronoid is. It should look like this, and that fragment is displaced into the joint, causing this joint space widening and a bunch of bone edema. You can see that the physes are still open here and here, and you can see this big joint effusion. So just be aware that small fractures can be challenging regardless of the modality. Be pretty careful in kids who have apophyses and trying to figure out, it's something that we spend a lot of time thinking about, what age the patient is in terms of skeletal maturity and the order of the ossification centers maturing. But be aware of this finding. All right, so there are some high yield, hopefully, findings that we can look for on radiographs of the shoulder, the clavicle, and the elbow. And I think if Andy is up for it, we could try doing some questions, and you could answer A, B, C, or D for these radiographs. You can see the AP, Y, and an oblique axillary view showing either A, a Hill-Sachs and Bankart lesion, B, a reverse Hill-Sachs and reverse Bankart lesion, C, a posterior glenohumeral joint dislocation, or D, an AC joint dislocation, specifically a grade 4 AC dislocation. So Andy will let me know when it's time to go to the next exciting case. And I figure let's just talk about this case now, since this is a potentially interesting moment to provide the answer. So on the AP view, this is a Grashy view. You can see the glenohumeral joint space. So one reason that people like the Grashy view is you can look for joint space narrowing with osteoarthritis. This is a nice joint space. We can see the humeral head is congruent with the glenoid. The AC joint is hard to see. It looks like it's probably congruent so we follow the undersurface. So that's all good. Then on the Y view, here's the Y formed by the scapula coming down. Here is the, we know the glenoid is here, and we know the humeral head is here. And so there's a lot of anatomy all projecting over each other, but the humeral head is in the right place. It's not dislocated anteriorly. It's not dislocated posteriorly. It's congruent. That's not to say that it has always been where it should be. Of course, there could have been a transient dislocation event. As we look at the third and most exciting image, this angled axillary view, the Boutin view, you can see that the glenoid and the humeral head are indeed congruent. Sometimes the Hill-Sachs impaction deformities at the posterior lateral aspect of the humeral head are pretty shallow and hard to see. But the idea behind these oblique axillary views is that you profile where the Hill-Sachs lesions usually occur, the Hill-Sachs impaction deformity. And then of greatest excitement here is as we follow the glenoid. So here's the posterior glenoid rim here. Here's the anterior glenoid. And as we come, we see that there is this fracture fragment with a linear lucency in between the anteroinferior glenoid fracture fragment. This is a bony Bankart. So this is a Bankart lesion and a Hill-Sachs lesion. And indeed, the correct answer is A, Hill-Sachs and Bankart lesions. Pretty awesome. Next, we have this exciting case. I wonder how I get rid of that. So this case is of the elbow, and sometimes things are challenging, but we're going to give it a go. Oh, this is funny, my typo. I thought I had corrected this. A radial head, and we'll put up the poll for people. So the choice is given between the 3 views of the elbow showing a radial head fracture, a humeral capitellum fracture, a humeral condyle fracture, and an olecranon avulsion fracture. And we did get the opportunity to see all of these derangements during the last 45 minutes. Radial head fracture A, humeral capitellum fracture B, humeral condyle / epicondyle fracture C, and olecranon avulsion fracture D. Oh, wow. What a sharp crew. So it looks like this election was successfully carried out with a clear majority of 82% favoring that this is an olecranon avulsion fracture. This fragment is a lot smaller than the one I showed previously. And you can see that it is actually displaced quite a bit away from this enthesophyte at the posterior olecranon, but there is this soft tissue swelling. And, this patient obviously might have some weakness and extension or pain posterior to the olecranon. And we have to have sort of a high index suspicion. Sometimes there will be little artifacts or things on the exam, and you're not really sure, oh, is that just, something that's artifactual? But this, in fact, would be concerning for an olecranon avulsion fracture fragment. Just to run through some of these other possibilities, we did note that the anterior fat pad is normal here on the lateral view. It's not displaced. We don't see a posterior fat pad. So there's not an effusion that we would see with an intra-articular fracture, such as a fracture of the humeral capitellum or a fracture of the lateral condyle and epicondyle, both of which we saw. And just to drive it home, speaking of artifacts, I've got this red line here. This is just sort of a bonus case, and I'll take this just because I know it's getting late and we're getting towards the end of the hour, but this is the corresponding set of images from the MRI. And the sagittal plane, a T1 weighted image, shows here is a high-grade partial tear in the triceps tendon, particularly the long head is involved with this retraction. You can see how hard it is to see that little speck of avulsed enthesophyte on the MRI. But there are some deep fibers of the medial head of the triceps that are still intact, keeping it from retracting even more. So here on the coronal plane, there's the olecranon. Here is the distal aspect of the triceps that's torn and retracted about 4 centimeters proximal to the olecranon. So here again, this is an olecranon avulsion fracture related to a distal triceps tendon tear. So with that, I would say we have successfully achieved our objectives, talking about some high yield radiographs of the shoulder, clavicle, and elbow. Thank you.
Thank you, Dr. Boutin. That was fantastic. Great pathological examples on X-ray, plus their correlates on CT and MRI, and a few examples of when you would want to go further with getting CT and MRI. You also gave some examples of commonly misdiagnoses like grade 4 AC separation, posterior shoulder dislocation, and then small fractures on in the elbow. Are there any of those or other things that you didn't mention that you would say are most commonly missed? Just curious.
Yeah, so I think we were sort of talking about traumatic things that we might see with a sports medicine practice. And so sort of focusing in on the fracture and malalignment issues. I think that those are sort of the major bread and butter cases and the major things that I worry about that I have included on my checklist of looking for things just because I know that they can be missed. So, you know, for example, with that medial clavicle fracture, you know, that's the kind of thing that if you have a question, you can discuss with the radiologist and say, you know, are you confident that there's no medial clavicle fracture if they have post-traumatic point tenderness there? And likely they will, you know, give you what you might laugh at, like I can't rule out a medial clavicle fracture. And so that, you know, I think many of us view the radiographs as a screening exam. And you know, using clinical judgment, one should not feel like it's the last word, either getting clinical follow-up, radiographic follow-up, or if it's a more urgent issue, some advanced imaging.
Mhm. Thank you. Are there any views of either shoulder, clavicle, or elbow series that tend to be more commonly, I guess, not done ideally or as correctly?
You know, it's interesting. I think most places would have a standard 3 views of the elbow. Sometimes if there's concern about a radial head fracture, there will be an additional radial head view. And I will say that those coronoid fractures do get missed all the time, and they herald the presence of a transient dislocation event in the elbow. So it's really good to have that on the checklist, not just the radial head. I think there is just a huge amount of variability that we see in the shoulder series that are done. I don't think there's any right or wrong way. I think there are, you know, some people that I work with feel very strongly they just need 2 views. Other people will get 5 views and everything in between. So as a humble consultant, we have, you know, each referring provider has their own, especially the orthopedists, have their own series that they like, and we do it. So I think, you know, there could be a research project saying, you know, can we really get by with 3 views rather than 5 views? I think 3 views out of the, say, emergency department in a post-traumatic setting is, I would say, a minimum standard, because you really, if you don't have an axillary type of view, it could be easy to miss, for example, a posterior dislocation.
Mm-hmm.
or
Great.
coracoid process fracture, for example.
Thank you. So I'm not seeing any new questions in the chat. If anyone thinks of any after, please feel free to reach out and we can relay that to Dr. Boutin. But thank you again. That was really wonderful. And I'm excited to say Dr. Boutin will be back in the future for another series. So I'm looking forward to that.
Likewise. Thank you so much, Dana.
Thank you.